Today's presenter is Kathleen Ratcliffe, and she is the founder and executive director of Upstream Prevention. She is an ICRC certified prevention specialist with a master's of public affairs from University of Missouri and a BS degree in psychology. While working on her master's in public affairs, she was awarded the Mel Carnahan Public Service Fellowship and was the 2013 Stanley Bontner Award recipient. She got her start in prevention as a research assistant for Missouri's Partners in Prevention before moving to Indiana to work with the Indiana Prevention Resource Center at IU Bloomington as a research associate and community prevention specialist. She is a trained facilitator for the nationally recognized substance abuse prevention skills training, ethics for prevention, and the Question, Persuade, and Referral program, the QPR program. She has served as a trainer, technical assistant coach, and evaluator within the prevention field in the past 9 years, and she is absolutely fabulous to work with. So here is Kathleen.
Thanks for letting me be here or inviting me to be here. I have several slides put together. Kimbra's request was to chat about community assessments as kind of that basis that the LCCs at least use for their comprehensive community plan, I believe is what it is. My acronym here is CPP. I don't think that's right. My approach to assessments is a little bit broader than probably what a lot of us are used to working on. And part of that is because of my origination and start in prevention way back when I was in Missouri. So we're going to talk about kind of the basics. I'm going to get on a little bit of an upstream soapbox a little bit. So we've got, I think, about 20 slides, and we'll see how quickly we get through them. I promised I would not go over. So we will get started. So for those of you who don't know about Upstream, which is probably quite a few, Upstream Prevention is a nonprofit based in Johnson County, which is just south of Indianapolis and Marion County. We were founded in 2015 with a mission to support systems level changes to promote public health. So specifically thinking about behavioral health within the realm of public health, which we know SAMHSA defines as both that mental, emotional well-being and actions that affect wellness. So what might be a little bit different than several of you on the call is that we don't just focus on substance misuse. We also expanded out into focusing on suicide, mental health promotion, anything that we can do to try to increase quality of life, to make individuals have easier access to easier choices, easier access, and filling some of those systems gaps to get the resources that they need and want, anything in those realms. We are primarily funded through governmental grants at both the federal, state, and county level. We also have a couple of private and community foundation grants. And then just like most nonprofits, we accept donations to cover all of those things that the grants won't cover, because that tends to be quite a long list sometimes. And so we're going to get started with a little bit of a chat about public health, because that is part of our mission. So public health uses a three-pronged approach to prevention and intervention, which you can see here on your screen. Most of us, again, probably don't have necessarily that public health background, so this may be a little bit new for you. But it is this idea that there are three categories or types of approaches that we can use to address public health issues. So those three items are the environment, the agent, and the host. With this idea that threats to public health require a susceptible host, which is often a person, an infectious agent, which is, when we talk about substance misuse, it is that substance, and then a supportive environment for those two things to connect and thrive. So an environment that helps spread an infection is likely going to, use that susceptible host and that infectious agent to impact our living conditions. Public health in this specific model started more in the disease area. So if we think about like CDC is the Centers for Disease Control and Prevention, but it's focusing a lot on those kind of infectious diseases. So when we think about public health, though, we can think about interventions that target any of these points of the triangle to impact the disease or the item in the center to get it to improve. And so when we think about maybe addiction, we could look at addiction. If we were targeting the disease of addiction, we would look at maybe doing prevention strategies that target the host. So how can we target individuals? I think of this probably a lot in primary prevention of how do we give kids resistance skills. We can also think about those that are aimed at the agent, so the actual substances. So a lot of the enforcement or intervention strategies that we might use. So cutting down on those that are selling drugs or, passing counterfeit pills. Those would all be targeted interventions at the actual agent. And then we can also think a lot about the environment. And so this is where a lot of what Upstream tries to think about in terms of systems change, but how can we make it so that it's an environment that is not helping either that susceptible host or that agent engage in the behavior that we're trying to address. So this could be, public health campaigns, so a lot of media campaigns, things that, maybe we're fixing some gaps in the system so that an individual who wants to or is ready to receive treatment doesn't wait for 6 weeks and waits for 6 weeks in the environment that is not maybe the healthiest for them. We can attack each of these different pieces. And what is really important, and that we'll talk about probably throughout this, is that we can't just attack one, right? So we can't just educate our way out of, the opioid use epidemic that we have right now. We have to be able to address each of these categories in order to actually see meaningful change. But we also have to address each of these categories at various levels, right? So if you haven't seen the Socioecological Model, it's on your screen for you, but it's this idea that in order to be comprehensive, we can't just, like I said, we can't just target the individual, and we can't also just target society. We can change rules and policies all we want, but if we're not giving individuals and peer groups the skills and the knowledge that they need, it's not going to be as effective. So when we can think about how there are different contexts and different levels of influence on an individual, and we address it at that comprehensive manner where we're addressing at that individual level. Again, maybe we're teaching refusal skills to middle schoolers, that interpersonal level of how do we get youth to hang out with positive peer groups, but then how can we also build a community that is not accepting of underage alcohol use, and then set good policies in place at that, county or state level or federal level to encourage that youth aren't using. So tackling, for that example, would be tackling alcohol use maybe, but we can tackle it at each of these different levels of an individual's interaction. For those of, I didn't look to see who was actually in here, but for those of you who are in here and have seen me present before, you also hopefully know that I like to be interrupted. So if you need to interrupt me, you can type in the chat, but I may not see it, but you can also unmute and just interrupt. I'm okay with that too. So before I move on, are there any questions on these pieces yet? Okay. All right, I usually tell people to interrupt me earlier in the system. This model or this graphic may be a little less familiar to each of you, but this is the continuum of care, and this is where I think we really have a good, or at least a better look at how can we tackle a challenge, and then again in this case specifically substance misuse, but also not just from the prevention realm. So Upstream's background and Upstream's mission and focus is more in that prevention area. A little bit of harm reduction sprinkled in, but we don't do treatment. We don't do enforcement. We are in that prevention education, category. But we also know that in order to have strong community outcomes, we have to have treatment available, recovery supports available. We have to have that enforcement that happens as well. And so those last two models, I'll zoom back a little bit. These focus, the public health focuses a little bit on how we might change the environment through enforcement of some of that. We might be able to change, some of the host aspects through treatment and some of that. But all of this, the way we have been taught, at least the way I was taught since I've been in Indiana, is that we focus on this aspect in prevention, and then we focus on a different aspect for treatment, and we focus on something different for enforcement or, justice intervention. And what I like about the continuum of care is that it gives us a little bit more of a comprehensive look where we can see exactly how prevention and treatment interact and where, we might be able to reach an individual across that continuum. What it does miss a little bit more so is that enforcement and some of that justice piece. But we could also think about individuals' interactions into the continuum of care as then a law enforcement ability to push them maybe in one direction or the other. So if we think about individuals that are maybe arrested for a substance related crime or for a crime that had a substance misuse underlying aspect. So maybe they were drinking and driving or driving under the influence or, maybe breaking into cars and stealing things in order to, sell them and have money for their activities. What could we do from that enforcement aspect that might put them onto this continuum of care to get them to that space of recovery? And so we can think of that as maybe some of our drug courts. In Johnson County, we call them our problem-solving courts. And so, that ability to pull them into this continuum of care to get them to that place where they can have those supports that they need. So when we think about jumping back into this continuum of care, where I think depending on your role or why you came to the LCC or the DFC, if we've got DFCs in here, most of you probably live in either the right side or the left side of this, unless you're, again, like I said, a law enforcement individual, and then you might think about where can your interactions, where do they feed in, or what happens to the people after they've interacted with you. So you arrest someone, you pull someone over, what happens then, and where on this continuum might they fit? And all of this is to say, why does this matter? Why did I just give you a 30-second crash course in some of these things? And 30 seconds is probably legitimate how fast I'm speaking. But on your screen is one of my favorite cartoons. It's a web cartoon. It's the Awkward Yeti. And it's to talk about and to emphasize the intersectionality of things. So every day we have the ability to choose one path or the other, or every day we see where paths converge. And so that convergence is what I wanted to focus on, because I think the LCCs have a more unique ability to focus on the convergence of prevention, treatment, and intervention, which is great. The challenge that LCCs are faced with is that a lot of times what we focus on, or what LCCs focus on, is just substance misuse. And I realize that that is in the statute, that's in the code, that is what we're supposed to do. But what challenges that provides us is that we can then miss a lot of things. We can miss the underlying mental health challenges that are impacting our substance misuse, or the economic instability or deprivation, or various areas that are impacting the reasons why individuals are either using substances to cope or making decisions that we maybe wouldn't want them to. And so this intersection of prevention, treatment, and intervention is also an intersection or an opportunity for us to think broader about how do we do strong public health work? How do we really dig down and find those challenges where we can identify underlying factors to then actually address, some of this substance misuse. So all of this matters is because we want to address those intersections, and that is what Kimber gave me the permission that I could do a little bit today. So I know that the comprehensive plans were already due. They were, due at the beginning of the month, which is also one of those where I would not want to toss something big, broad, and different on you, the month before they're due. So this is perfect timing in thinking about when you have to do those next year, what are some ways that you can maybe take a step back or several step backs and look at the entire context and situation that's happening in your community, to identify what are those patterns and trends that are contributing to your environment that is then contributing to your substance misuse and your substance problems. That may be thinking about social determinants of health. It may be thinking about your ACEs and what does the level of trauma look like in your community. It may be sticking with just those risk and protective factors that you've maybe used before, but maybe taking an extra step and look at what are some of those shared risk and protective factors that we know influence some of our mental health challenges and some of our, food insecurity and some of those things. How can we use all of the research that's out there? Again, whether it's developmental assets, social emotional learning, building of skills, how can we use all of that to really dig down and see what are some of those underlying factors that are then giving us or contributing to that environment so that we can then better address it in our plan that you then build through that public health approach. But Kimber did want me to talk about assessment. So we're going to start with assessment, right? So when you think about a community assessment, you're really trying to think, what does my community look like right now? So again, specifically for the comprehensive community plans and a lot of things, we are a little bit siloed in Indiana. So this says substance use or substance misuse, you could throw in there. I encourage you to really think, what is the nature and extent of the problems and the related behaviors in my community? So think about what are the consequences we're seeing, and then what are the problems that are more or less leading to those consequences? Digging down a little bit more, what are those risk and protective factors that influence those behaviors that's causing those consequences? And then what resources and readiness do we have in our community to actually address any of those problems we prioritize? So when we think about a community assessment, to me, and then in an ideal world where we're all very well paid and have plenty of time, it's thinking, how can I build this big, beautiful plan that we can actually look comprehensively, what are our systems, what are our behaviors, what are all of the things that are happening, and then use our planning aspect to dig down into it. I think that is a very Pollyanna view. We don't usually have time to do any of that, or the money to do all of that, or even if you did, the data and the way that you need it that's readily available. But thinking about what is the end goal? How can we get a step closer to that? Sorry, I was just scanning the chat box real quick. So when we think about all of these items, again, we can focus on just a single behavior or just a single, quote unquote problem in terms of like substance misuse. We can also apply this structure to, assessing suicide or mental health challenges in our community. But my approach is that we should look at it as broad as possible to see what are all of the things that are there to then narrow down what can we maybe do about it. And so when we're thinking about these problems and behaviors, we're thinking about, how do we understand it? We can't change something if we don't understand it. So we need to think about what is actually happening. What are those problems and behaviors that are occurring in the community? What's going on? As specific as we can get, as county driven, or if you are focusing on a specific city or zip code, as far down as you can drill to get some of that data, because you want to also then think about how often are these problems and behaviors occurring and where are they happening? If we can, and this is where Indiana does not have a lot of data, at least in my experience, but what populations are experiencing those problems and behavior. So if you have any sort of health inequity or a social justice lens, can you actually tell me or tell somebody what your populations and various populations are looking at and experiencing, and what, again, are then those risk and protective factors that are influencing those behaviors? And part of it is that we all have different data sets available to us. Again, some of that data is readily available. Some of it is, you have to jump through a lot of hoops, and some of it we know exists somewhere, but we just can't get to it. So again, it's that how can we get as close as possible to getting as clear of a picture as possible so that we can try to understand what are our problems and what are those behaviors that are causing those consequences in our community. And as we start to grab those, we then have to think about them and prioritize them and look at them. Again, as we look at those different data pieces that are collected, we also have to be careful at how we look at that data. So we can look at things that have a high magnitude so that they seem to be a really impactful area. So if I told you that a community had 100% increase in drunk driving fatalities, we might be really, really concerned. But if I went from 1 death to 2 deaths in a population of 500,000, that might not actually be a big magnitude, although it sounds like it because of that small number and that percentage change. Again, 2 deaths is too many, right? Too many, but is that the best area to focus all of our efforts if we are then, maybe losing, 20, not 20,000 is too high, but maybe we lost 200 to an opioid overdose. That might be a better spot to put our time, even though the rate might be small or the percent change might be small, but it's a bigger impact on individuals' lives. We might also, or really should, look at some of that time trend. So is it getting worse over time? I think that this is especially true as we are living in a almost quiet pandemic now. COVID is still out there, it's still real, but I feel like we are moving on quite a bit. And so now we're trying to see what does this look like now. Part of that challenge is that a lot of us are probably using pre-COVID data because that's all we've got. And then the next round of data that we get is going to be data that we gathered in the midst of COVID. And that's going to look very different from, the pre-COVID data, but it's probably also going to be very different from where we are right now. And so to some extent, the more time trend data we can get, the better, but we also have to pay attention to those contexts that exist around it. And also, again, recognizing that sometimes the data is what it is, and that's all we can do with it. We can use it to the best of our ability, but just remember that there is the ability to shift and change as we need to. Severity, I kind of already talked about a little bit, but both of my examples were mortality. But thinking about how severe is it? We might talk about overdoses as maybe not being the getting worse over time or not having the largest magnitude, but people die from overdoses, right? And so that is something that is at least worth considering and at least worth weighing, is that it has a high severity. People are dying from opioid misuse. But also, we also need to be concerned about maybe the large portion of our youth that are starting to use, and if that's increasing. And is that something that is then leading to, down the road, some of the mortality challenges that we're experiencing? And then to the extent possible, that comparison and trying to compare as much as possible, apples to apples versus apples to oranges. I used to joke that they're both fruit, so sometimes that's all we can do, right? We can compare apples to oranges because that's all we've got. A lot of it comes down to how good is our data, and that applies to all of these categories. But thinking about, we get and try to get as much and as good of data as we can, but then sometimes we have to look at it with a grain of salt. But also, most of the time, I would say probably 95% of the time, as long as you are looking at the data and following the direction the data is going, you're not probably making a wrong decision. If I were in the SAPS training that I used to train a lot more, I don't anymore, we talk about, should we tackle youth marijuana use or youth alcohol use? And in that case study, the data is very compelling for either direction. You could easily make a case for doing one versus the other, but it comes down to what is best for the community, what do you have the buy-in from the community, and those things are things that nobody outside of your community would be able to tell you, oh, you made a wrong step here. It's really looking at some of this data, looking at the approaches that you can take, and then making the best data-driven decision you can, understanding that there's, not necessarily a right or a wrong for some of these. And then when we start to, identify what some of those problems are, we then got to start to think about the why. Like, why are these things happening? Why are not necessarily why are these problems, but why is our youth using more? Why is that increasing? And so what we encourage you in prevention, and this applies again also over to mental health and some of those other areas, is to think about the risk and protective factors. So we can think about risk factors as those characteristics that are associated with a higher likelihood of problem outcomes. So again, if we focus on substance misuse, we might look at a risk factor of the level of perceived risk. So we know that individuals are more likely to engage in behaviors that they don't feel is risky. And so if I don't think marijuana use or prescription medication is risky, then I am more likely to do it. Doesn't mean that I will. Doesn't mean that it is written in stone it's going to happen. It's just as associated with an increased likelihood. If I think that my parents aren't going to pay attention to me drinking or using or don't care, or that will use with me, I am more likely to engage. That is a risk factor. Whereas a protective factor is, again, those characteristics that exist, but these help reduce the likelihood. They lower the likelihood of problem outcomes. A lot of times when we think about protective factors, especially in a lot of what Upstream does in the mental health realm or in suicide prevention realm, we focus on that social connection. So do I have somebody I can lean on? And do I have those individuals close to me to provide that support? When we think about that in the substance misuse realm, it still exists as a protective factor, but it's that, do I have positive social connections with peers that are making good decisions or that will support good decisions? When we think about youth, are they surrounded by other youth that are making pro-social decisions? When we think about adults, are they surrounding themselves with individuals who will support their recovery or will support their decision to go get treatment or seek out treatment? It is important on these, if you've not heard about them before, they don't balance out. It's not like I could look at somebody and say, oh, you've got 3 risks. Great, here's 3 protective factors. You're good to go. The protective factors we can think of more as bubbles. So if you think of like a bubble boy who lives in a protective bubble and can bounce off things, or those toys that, not toys, but those inflatable things that you can buy and run around and run into things and bounce off of them. Those are more for like protective factors. They're things that can help buffer us. They can reduce that likelihood of the problem outcomes, but they don't wipe it out completely. When we think about these things, this is where, protective factors, we can also think about some of the resilience. And so how does this ability to bounce back exist? So when we think about our problem behaviors, we want to think about what are those underlying factors that impact them. The great thing is that there are factors that impact multiple problem behaviors. And so then we can start to look at those, the data that we might be able to get on those risk and protective factors and do that exact same examination. Is it likely the largest impact on the behavior that we're wanting to look at? Is it getting worse over time? If you look at the Indiana Youth Survey over time for their perception of risk of substance use, it is increasing. And the fact that youth are at higher risk, more youth are at a higher risk now for thinking that substances aren't harmful. We see this a lot with marijuana use. When you look at like the Monitoring the Future survey, the perception of risk of harm of marijuana use has decreased as marijuana use has then increased. And so we can think about, what is a major factor related to marijuana use in youth. It is probably that perception of risk. It's no longer seen as harmful as it was maybe 20, 30 years ago. So as we start to pick out some of these risk and protective factors, we also want to do that exact same examination. So just because a risk factor may be playing into one of our problems doesn't necessarily mean that that's the one we go after with the whack-a-mole stick. It's looking at which of these is the most malleable, is the biggest, is getting worse, has maybe the most severity, and is drastically worse compared to our peers as we can. And all of that is great, but you also have to have a community that's ready to tackle it, right? So when we think about how ready is the community to both accept that it needs change, but then also to take that action. So one of the things that we've had that popped out in one of our community conversations that I was in with some of our partners is that we can tackle the substance misuse disorder all we want, and we can try to build those recovery spaces. But until we actually get our population to identify, yes, we care about all people, individuals who use and misuse, drugs are also people, and we care about them. Until we can remove some of that stigma and actually get some of our population to say, yes, they matter and we should do something for them, we're not going to be able to make the big sweeping changes that we need to see. So we've got to get our community ready, which hopefully they are. But if not, we have to maybe step back and then move in the direction of picking out items that have that high changeability. So as we start to prioritize some of those targets, we need to think about, again, those problem behaviors, the underlying risk and protective factors that relate to them, and then also of those items, which one do we have that community support to recognize that it is a problem and that we can change it, and that they've identified that it's important. And so this is where we want to try to pick things that are at that high level of importance, which usually, you know, our data or our assessment group or the people looking at the numbers and looking at the data can identify what is high importance. But that changeability is where the community aspect comes into play. So we may need to look at and assess our resources in this aspect of, do we have enough resources? Is this something we can change? And do we have the buy-in to move there? One of the perfect examples that I always think of with this changeability is an example from when I worked in Missouri. I worked with Missouri Partners in Prevention, and we worked on college campuses to support community coalitions. And those community coalitions work to reduce high-risk behaviors by students. And so if you can think even stereotypically of a typical college student, we were based at Mizzou, which moved to the SEC while I was there, which is a very big athletic, celebration, all sorts of things. One of the things that some of our schools wanted to change was tailgating policies, and what is allowed and what isn't allowed and where is it allowed. And that could have been a really great approach in some of our smaller schools. But once Mizzou moved to the SEC, that was essentially something that we knocked down as something we weren't even going to really prioritize, because it was not something we could change. We could maybe change it on our own campus at Mizzou, but with the SEC, with teams that travel and came to us to play from those, very well-established football schools is what I'm thinking of primarily, where they show up on Wednesday for a Saturday game and they camp out and they, drink and cook out and have fun and tailgate for 3 days leading into the game. That's probably not a culture that we can change by our lonesome, only when they come to Mizzou. And so that was one of those that we're like, we probably can't change that culture, but we can increase awareness. We can increase, some of these other aspects to try to make it a little bit safer, but we're probably not going to be able to cut down and change this policy that has, or practice that has existed, in the SEC for a really long time. It's also thinking about, is it within your sphere of control? One of the benefits of an LCC is that you, at least theoretically, should have a lot of different partners at the table who each have their own probably sphere of control, or at least have their own missions and reasons they're there and the things that they do. And so what is nice is that it may not be within the sphere of control of the, maybe your prevention coalition that's there, but if you've got, law enforcement or treatment providers and they can change something, that might be something that is changeable for them, even if it's not changeable for, a different entity that is at the table. And as much as I love data, at some point we have to actually stop and do something with it, right? So when we think about a comprehensive community plan, it should include a lot of the data pieces, but it should only be built after you've actually started to look at those data pieces. So to have a comprehensive community plan, we need to do all of that digging to get those data points. Again, my encouragement is to step as far back as you can to gather comprehensive and holistic data points, and then start to narrow it down to think about, okay, now what is within our sphere of control, what is within the things that we can do, and how can we prioritize it best. But you want to think about in your plan or in a separate document that maybe isn't your plan, to have these items outlined. So you want to have those problem behaviors, one or more, identified, as well as why. So again, that data to back it up, those risk and protective factors, any other contributing factors, or any of that underlying, again, why these things are happening, why these behaviors are happening, and how they were prioritized to the extent that you can. Any of the resources, the gaps, the readiness, any of that environmental contextual information that is useful, so that you can either identify challenges ahead of time or identify partners that you can leverage. If it is a full plan and you're in that planning stage versus just that assessment stage, you can start to think about what are those interventions. And then I'm a data research evaluation nerd, and I would not be a presentation by me if I didn't tell you to build a logic model as well. So a logic model is really just thinking about, where is my data, what am I trying to change, and how am I going to get there, and stepping it out from that. So if I want to change youth substance behavior, specifically alcohol misuse, what is the factors that I'm going to address, and how am I going to do that? Because if nothing else, it gives you that ability to, again, take a step back and look at it with a critical eye and say, does this actually make sense? If I want to change youth alcohol use, putting prescription drop boxes in does not make sense. It might make sense to address youth prescription drug use, but not necessarily alcohol. So it gives you that kind of gut check that you can step back and do. And really, the other nice piece is that if we imagine that each of these items exist or should exist in a comprehensive prevention plan, for those of you who are LCCs, the nice thing is that they're all in there, right? So the first piece, one of the first things that you have to do in your comprehensive community plan is to identify what are those risk factors and what are those protective factors, but then what are some of those resources and assets? So those are the things, what do we have? And also, what are we lacking? What are those gaps? And so you can think about resources as things you might be able to leverage for your capacity to address those items, as well as the gaps are opportunities for picking out or setting a direction and some strategies. Then for each of your risk factors, you do also have to identify your problem statements, right? So it's great to say that we've got a risk factor of low perception of harm, but what does that actually mean? What is that data that can back it up? How do we know? Let's build a statement that if we were to address these problem statements, we would likely impact that risk factor. And again, then what is the data that backs up that problem? I can't tell you how important it is to both get that data down so that you have it somewhere, so that in 2 or 3 years, or when you have turnover, or you sleep and you wake up the next day and you're like, where did this come from? To be able to have that number readily available, as well as the actual source. And it's not, you're not in college trying to cite things for a massive research paper that you're trying to get published, but you need to give yourself enough source information that you can find it. And in the LCC case, find it a year later to see if it has any updated data. And if you just put the website, or a website, that is not enough information most likely for you to dig in. So as much data as you can do, whether it's in this report or as a comment or something like that, to be able to find that data again. And then you can actually start to think about what are those interventions? What are the strategies that we would want to do for each of those problem statements? And I think then you get to set your evaluation goals. Where do you want to be in a year or 2 years or 3 years for each of those statements? So as you think about this that's in your LCC, your comprehensive community plan, it should be based on a strong assessment, but a lot of this is really tackling that comprehensive community plan aspect and setting yourselves up for that evaluation and logic model building that would come a little bit later. So this plan doesn't have a logic model, but if you needed to finagle it around, you could probably easily take those goal statements and that problem statement and make it work, and be able to take that look of, if I address this goal, or if we meet this goal, will I have actually impacted this risk factor that exists? Oh, I was like, I don't know why it didn't change. It's because there's another one that popped up. So the challenge that I think the LCCs run into, or really that you run into anytime you're building something that you then don't always control the exact output, is that identifying those steps and identifying some of those strategies can be really hard when you don't already have those in mind, as well as trying to build this massive community plan that you then are hoping other people choose to implement. So the more buy-in you can get and the more involvement you can get from your community partners as you're building your plan, but ideally pulling them in as you're doing your assessment is going to help you as you get towards this this long run. There we go. So I think I'm almost on my last slide, but looking at like what do we do? So I mentioned a little bit that I have a little bit of a soapbox in the fact of de-siloing. My start in prevention, I worked, like I said, for a statewide, more or less consortium that addressed high-risk behaviors of college students. But if you think about all of the high-risk behaviors college students can engage in and probably do engage in, it is more than just substance misuse. We talked about gambling and mental health and suicide, anxiety, vaping, driving and texting, driving and not wearing your seatbelt, all sorts of things. And so one of the things that we did really well is that we had that central hub where we could address all of the things. And so Upstream was created, or named, I guess, from the prevention parable, which if you haven't heard of, you can see it on our website because I don't have enough time to tell it to you all right now. But we really are seeking to support those systems level change because we want to be able to take that step back, move upstream so that we're actually addressing those root causes. And what we find is that when we start to address some of those root causes, it is not a root cause that only impacts substance misuse, or it's not a root cause that only impacts somebody's mental health. It is most likely a root cause that impacts all of these challenges or problems or consequences that we see that we want to fix downstream. And so when we move that upstream aspect and we start to look at those underlying pieces, when we take those couple steps back and actually look at our community assessment in a holistic way that looks at different behaviors, we're able to then address things more effectively and work smarter down the road. Because as somebody asked in the chat that I delegated off to ICJI, we don't have a lot of money for a lot of this, right? And especially in a pandemic and in COVID times, there's a lot of money that got tossed out there, but that money is not staying forever. And so when we have to work and do just as much, if not more, with less money, we have to start to think about how can we start to reduce redundancies, work smarter, and in my opinion, then that moving upstream, do more there. So I have on the screen and I'm done. So Kimber can take it away whenever. If you need to email me or want to email me, you can email me there. That QR code will get you to our website, which is the web address right next to it. If you have a QR reader on your phone and you want to, you can also follow our Facebook page. That's the dinosaur QR code. And I am done. Kimber, it's all yours. Or whoever.
All right. All right. Thank you, Kathleen. Does anyone have any questions they want to ask Kathleen while we're all still on here? If not, she is a wonderful resource and has a lot of information and is just Kathleen does a couple of our evaluations, so she's very fantastic. And if you guys ever have a question, I'm sure that she can point you in the right direction. Right. Sadia, do you have an update from ICJI?
I'll go ahead and give that because I have
okay.
a couple things. Sorry. Yeah, so we have a couple things to update you all on. So we would like to welcome Janet Benedict to our team. She is replacing Corey. We have not sent out an email yet to introduce her to everybody because we realize it is a busy time and she's onboarding and learning the comprehensive community plan. So we will be sending that out within probably the next 7 or so days. So sometime next week or early the following week. So we're excited to have her here. And Janet, if you just want to say hello briefly so everybody can see your face and hear your voice.
Sure can. Hello, everyone. I'm excited to meet you and work with all of you in some capacity. It'll be a fun new journey.
And we are really excited. Janet is an internal transfer from here at the Criminal Justice Institute. She's been with us as an agency for a while. She spent the last couple of years in our compliance division, going out and making sure that our grantees were compliant with our contracts and federal standards and other items that may arise. So we are really looking forward to both her background in that and also her technical ability to really help us expand some of the nuanced technical assistance that we really want to be able to enhance. In the chat, because I think Kathleen's presentation was wonderful, and I think she really got to the spirit of what we were trying to do when we overhauled the comprehensive community plan from a non-structured document to a semi-structured document, to really get to the heart that it is a living document, and you know, the conversations at that local level that you're engaging in need to be meaningful and based around whatever sort of logic model you all have developed, which is hopefully what comes out of that comprehensive community plan. So in the chat, I did put some things that we've sent out before, live on our website, but just because it's a consolidated place, I wanted to send them again. So there are quite a few resources that I threw in there for you all. From the updated state epidemiological outcome work group report, which is funded by the Division of Mental Health and Addiction, their community mental health center reports, they are not super up to date. They're 2019 and 2020. And again, that's their data. So unfortunately, I can't do much about that. Our website, where we have a lot of the curated data for you that we think could be meaningful for you as you attempt to have those active conversations. And I put on there the Kids Count data book. If you haven't seen it from the Indiana Youth Institute, this year's data book is quite impressive and very heartbreaking at the same time. Which goes along with some of the data we've seen out of the CDC, that the generation that is really coming into adulthood is the most depressed and anxious on record. So I was going to say in history, but on record, as far as we know. So I also noted that there was the question from Howard County. I know we've said we're looking at this issue before. It is a complex issue that, I encourage you to have conversations with your judges and your prosecutors and your whole apparatus there in your county to make sure that they understand, the importance of the fund there in the county. We are continuing to try to explore how to better understand it at our level. Part of that process began with us looking at what is carrying over from year to year to truly understand if the dollars are being used, what is the carryover, is it truly diminishing? And there is some diminishment, but there is also quite a bit of carryover from year to year, and that's okay because these are non-expiring dollars. But I don't think it's a very simple issue to solve. So I think it's a really complex issue with multiple parties that we'll have to better understand moving forward. And we are absolutely here to advocate for you at the state level, but it really does need to also be a conversation with the local representatives within your community. Finally, I'm just excited. We've seen just some excellent comprehensive community plans. I know Sadia has been extremely busy, so I just want to give her a big shout out. We do miss Corey, but he also left right at the start of the CCP, so couldn't necessarily have a worse time for that. But we wish him luck in his future career endeavors as a prosecutor with Marion County. So please know that we're on our timeline still, so we expect to have everything pushed through and approved as we would, and we're excited about that. But also please just be a little patient if Sadia takes a little bit longer to respond, because she is slightly inundated at the moment.
I would like to add one last thing here. I would like to remind all of you about the end of the year report, which is due on May 1st. Please know that this will be the last quarterly report for 2021 CCP. Therefore, you are required to include information about all programs that were funded in 2021. I will strongly encourage you to use the template that we send out via email on different occasions. We have sent out instructions on how to submit that report on the IntelliGrants. I would also like to remind you that meeting minutes are due with the submission of end of the year report. So please make sure that when you will submit your end of the year report on May 1st, you will also upload all meeting minutes. If you have any question about instructions or about template, please reach out to me. I will try my best to respond to your email as soon as possible. And I think we have covered everything today. Thank you so much.
I did see one final question directly to me, but I think it might apply to everybody. So what I'm going to say is, I know I posted these links for you to click on, and I also uploaded a couple PDFs. I'll have Sadia send them out via the BH@CGI email to everyone, just to facilitate that access, to make sure that you have multiple ways of connecting with that information.
Thank you. Okay. There's been a couple questions that have popped in. Carissa, I believe Carissa Miller from Scott County. I think you would just reach out to Sadia at ICJI regarding the year-end report if you have questions. And then Rachel, she has a question about the minutes.
Yes, so Rachel, you will upload meeting minutes for the meetings that were done during last quarter. So I believe it will cover a time period after January 15th until April 15th. So all those meetings which were done during January to April will be submitted in the IntelliGrants.
We have reached our time. So if you want to stay on and have any questions for ICN team, please do so. If not, we'll say goodbye and see you on May 25th instead of May 26th next month because of the SEOW presentation that's going to be done on May 26th. So we're moving next month to May 25th, which is a Wednesday, same time, same bat channel, all of that. So, all right. Thank you, everyone.